and thank David and Max. I was driving here and there this morning, and I was listening to KNPR, our local NPR station, and I was listening to this terrific conversation about healthcare, and then it dawned on me, wait a minute, that's David. So, and David was on the radio talking about this important conference and the different leaders of the various industries that are brought together to talk about this critical issue. And it just struck me, this is exactly why we created a health law conference, to bring people like you to have discussions like this. And I just couldn't be happier and more grateful for your being part of this. I want to thank you for discussing this critical issue of affordable healthcare, and I want to pay thanks in particular to Professor David Rentlicker. Thank you, David, very much for doing this. And Professor Stacy Tavino and Professor Max Gack from the Public Health School. There's Max, thanks very much. Thank you, Max. And Associate Dean Chris Smith. The Health Law program is part of a wonderful series of partnerships that you see on the screen there. And it really is a collaborative enterprise, and I want to welcome our friends from across the community, including Michael Gardner, Vice Dean at the Medical School at UNLV. Thank you, Michael, for being here this morning. Las Vegas was the biggest city in America without an academic health center until Michael and the med school came to this town, which is already transforming the practice of medicine in this town. And I want to thank our great friends from the Culinary Union and Kathy Silver. Thank you for being here this morning, Kathy. So, my job is to get out of the way and let this thing actually start. It's a very impressive program, people from around the country, and I want to thank you for doing this. It's an honor to have you at the law school. It is really Exhibit A of why we want to have this program that is off and running. We want to keep you connected to the program. You have what everyone wants now. You have friends in Vegas. So it is great to have you here. And I want to welcome co-anchor Professor David Rentlicker. Thank you.
Well, thank you very much. Having the support of the Dean and the law school allows us to do these kinds of programming. So thank you so much for that. And as the Dean said, we're fortunate to have partnerships, the medical school, the School of Community Health Sciences, United Healthcare, and the American College of Healthcare Executives. So thank you all. And our team, Max Gack, Christine Smith, Haya Wang, and Louis Lim for organizing this. Thank you for all of your time and effort. This is an important issue. Fortunately, we had the Affordable Care Act in 2010 to provide access to health care. We've seen the number of uninsured drop by half, so that's been a big improvement. But it's supposed to be an Affordable Care Act, and we haven't made so much progress on the affordability side. And that's why we're here to talk about what we can do about cost containment. It's not that long ago that we spent about 9% of our GDP on healthcare, and we were in line with other countries. But in recent decades, we've seen our expenditures double, while other countries have gone up far less. And the question is, why is that happening, and what can we do to control things? And it's not only that we're spending so much money. Maybe it's not so bad. We are a rich country, and is it better to spend money on healthcare than on football tickets or yachts? And maybe this is, if you're going to spend money on something, healthcare is not a bad way to go. But we're not getting the full bang for our buck. If you look at how effectively we use our healthcare dollars compared to other countries do a much better job with their healthcare dollars. So, we want to make sure that we talk about so we're going to talk about what's the cost problem, what can we do about it, and what can we learn, especially not only from experience in this country, but from other countries. So our first speaker is from Brad Herring, and we're going to have Max Gack. We'll introduce him, and he'll start us off. So thank you all for coming, and I look forward to some great talks today.
Thank you so much. I want to thank you all for being here as well, and thank our sponsors and our speakers and our panelists. I will be brief, although I could probably go on and on, talking about Dr. Herring, who's an associate professor of health economics at Johns Hopkins Bloomberg School of Public Health. I was also once a student in his class, so this introduction is especially fun for me, but he's a prolific scholar. He focuses on economic and public policy issues related to health insurance markets. His publication record is very impressive, including journals like the Journal of Health Economics, the New England Journal of Medicine. His research has been funded by the Robert Wood Johnson Foundation, the federal government. the Organization for Economic Cooperation and Development. He also has spent some time in practice, including a year with the White House's Council of Economic Advisors. And Dr. Herring is a frequent recipient of teaching awards, which I can say are very well earned. So very much looking forward to his talk here. So without further ado, I'm going to ask Dr. Herring to come up.
Great, thanks.
Yep.
Just trying to get this thing to come back on. Here we go. Thanks. All right. So real happy to be here. So I'm Brad Herring from Johns Hopkins, and why are healthcare costs so high, right? So I was asked to come and talk about this as from an economic perspective, and in some sense, I'll start off by showing you a graph that you've probably seen in some shape or form similarly somewhere. So this is healthcare spending as a proportion of the economy, specifically percentage of GDP. We've got time here on the x-axis, the US in purple, some other countries, the UK, Germany, and Canada, red, blue, and orange. And you can see nowadays, like, we're just an outlier, right, in terms of how much money we spend on healthcare, right? 18% of our economy devoted to healthcare, significantly higher than other countries. Right? Little variation across the other countries, and I think we'll hear some discussion about that later on. But if you look at it this way, it actually wasn't always the case, right? The U.S. actually was in the mix for these OECD countries. So the other black lines are the different countries that comprise the OECD, and we actually used to be kind of in the mix, decades ago, right? So in some sense, this is probably pretty clear to you already, but I'll try and emphasize it as kind of an anchor for my subsequent talk. When you think about the question, why are healthcare costs high, right? You can kind of think about a certain set of answers that might be, well, the level of healthcare spending is high right now than it would be otherwise right now, right? So this is this whole notion of the level of spending, right? And we can think about different reasons, and I'll walk you through what I would consider some of the main reasons for why the level of healthcare spending is high. And sometimes those are going to be similar, but sometimes they're going to be different with respect to an alternative question, which is why are healthcare costs rising, right? Why is healthcare consuming an ever-increasing share of the economy, right? So to kind of think about this in the most simplistic terms, you've got the black line, which is starting off at a low level of healthcare spending, but having relatively rapid growth, and the blue line is essentially starting off at the same level, but relatively slower growth, right? And then follow on, thinking about the tan versus the black line, similar rates of growth, right? But different levels of spending at a point in time. Okay, so what I'd like to do for the next 40 minutes or so is tackle these two issues kind of separately. First, talk about explanations for the high level of healthcare spending, and then in the second half, transition into talking about explanations for the high growth in healthcare spending. Right? So it's not going to be super black and white where we can totally disentangle the reasons, because the reasons why we're at a high level for certain things are caused by high growth, right? But we'll still kind of take this approach, and then also try and focus a little bit on things that I personally would consider some of the main drivers for high levels of healthcare spending, high growth of healthcare spending. And specifically, I'll focus on three for the first half in terms of the high levels. Inefficiency associated with the tax exclusion for employment-based health insurance. Explain what I mean by that in a minute or so. I'll transition to talking about suboptimal provider payment policy. And then, as you would expect an economist to do, talk about the impact of market competition and perhaps the lack of market competition in certain healthcare sectors. Again, I'll then transition to talking more about the growth in healthcare spending over time. I'll mention a few, and not to give them short shrift, so I'll mention them. But the main conclusion is that if you really think about the growth in healthcare spending over time from a long-term perspective, it's really the growth and introduction of new technologies that are the main driver, okay? And so I'll be throwing a lot of charts at you, trying to make a lot of points, but what I'll try and do at the end of this 40 minutes or so is try and bring it together and synthesize it back into an argument that the technologies are indeed the driver of healthcare spending growth, and that on average, the introduction of these new technologies are beneficial, right? We're actually better off in a world that has MRI machines than doesn't. But having said that, at any point in time, a lot of the increases in healthcare spending actually probably don't have a lot of value. And one way you can kind of thinking about this reconciliation of this is that the technologies inherently are good. We should be glad we have them, but we're using them too often, right? We're consuming too much care, and then in turn, a lot of these reasons why we have high healthcare spending at a point in time, kind of consistent with this notion of use. Okay, so let me start with focusing on the level of healthcare spending and start off by talking about this notion of the inefficiency from the tax exclusion for employment-based health insurance. Okay, so real quick, the argument I'll try and make here is that health insurance through your employer, it's a non-taxed benefit. That in turn leads us to have more generous health insurance coverage than we would otherwise, right? Covering more services with relatively lower cost sharing. Most people other than economists think this is a good thing, right? But economists will say, well, yeah, it's a good thing for a part of the reason, but there's some side effects that we ought to be concerned about. And it's the inefficiency of increased utilization of relatively lower value services tied with that relatively more generous health insurance. Okay, so to make this connection back to the tax exclusion that I believe most health economists think is one of the primary drivers for high levels of healthcare spending, is to first off try and understand what is this thing you refer to as a tax expenditure. Right? So if you take several steps back and just think about the function of government, right? Whether it's a federal government, state government, taxes come in, right? Taxes shown here in green, right? Tax revenues come in, and then the government in turn spends this money on things in tan, right? So here for the federal government, Medicare, defense, Social Security. Right? Tax expenditures are kind of both, but neither, right? So a tax expenditure is something that's run through the tax code, but essentially it's not a tax you pay, it's a tax you avoid because we've set up the tax code to exclude certain things from being taxed, okay? And when we do that, when we exclude these things from being taxed, that's arguably providing a subsidy for those things, right? And then in turn, that subsidy is kind of like direct spending on Medicare, defense, Social Security. Okay? So, first point here, if you look at this figure from Congressional Budget Office, right? Tax expenditures in blue, right? Income tax expenditures in light blue, payroll tax expenditures in dark blue. It's a thing. It's a big thing, right? And then on top of that, if you look at the different types of tax expenditures, the employment-based tax expenditure is actually the biggest one, right? The one up top here, dwarfing, well maybe dwarfing is an exaggeration, but higher in magnitude than other tax expenditures that you generally think of, like the mortgage tax deduction, charitable tax deductions, certain income credits, and the like, okay? So, what's what's the story here, right? So this is showing actuarial values for health insurance coverage prior to the Affordable Care Act. Okay? So an actuarial value is a technical term essentially describing the extent to which health insurance coverage is generous. If you've got a generous health insurance plan that covers everything, we're talking about the right end of the spectrum where this actuarial value would be 100%. Right? Health insurance plan that on average covers about 60 to 70%, that's what the ACA has newly referred to as a silver plan, right? The silver, gold, platinum. Okay. So to go off on a slight tangent, just briefly, this is showing actuarial values in the individual market prior to the Affordable Care Act. And the big thing I want to mention is that there certainly was an issue of these so-called 10 plans that just were not like real health insurance plans providing real financial protection, right? So certainly an issue there, right? But the main point in terms of thinking about the tax exclusion, if you look at the distribution of these actuarial values in the individual market and compare it to the group market, there's a very different distribution, right? So individual market here, and so you can think about like the group market having some kind of incentive pushing people towards the right and having relatively more generous health insurance coverage. And that incentive, right, drawing people's coverage off to the right is essentially the fact that your employment-based benefit to you is not a taxed benefit, whereas your wages are, right? So on the margin, workers have a slight incentive to receive additional compensation, not through wages, but through untaxed benefits. Okay, so again, the economist kind of saying this is a problem, a little foreign to a lot of people because they're like, wait, like richer benefits is a good thing, right? I mean, in some sense it is, right? So we think that people being exposed to too much risk is a bad thing, and having insurance to protect people from that risk is a good thing. But there arguably could be too much of a good thing when people have what economists refer to as overly generous health insurance coverage, which leads them to consume relatively more health care. And then the key punchline here is that additional health care you consume in the platinum plan relative to the gold plan, it's going to drive up healthcare spending, it's going to drive up the health insurance premiums. People are going to go to the doctor more often. When they go to the hospital, it's going to be more expensive. But when you try and look and capture whether that additional healthcare spending is making people like healthier, the bulk of the research here, almost all the research, even all the research, is really kind of arguing on that margin, right? Modest health insurance to more generous health insurance isn't necessarily making people healthier. Okay. Second reason, right? So to take a pause here, right? Focusing on increases in the level of healthcare spending. And what I just tried to convince you of is that the tax exclusion is a contributor to that, right? So I'm just going to go over this briefly, talk about it later, but there's a lot of proposals out there to try and think about modifying the way the tax exclusion works to try and blunt this incentive to have relatively more generous health insurance plans. Second thing to talk about is suboptimal provider payment, right? So generally speaking, this is the notion that we've historically had fee-for-service, volume-oriented payment models that have led to overconsumption of healthcare, which in some sense builds on this prior literature of saying that people have insurance and they're like incentivized to receive more care. And then the other side of that coin is that providers being paid per fee for service have incentives to go ahead and provide that care, because as long as it's not exposing the patient to harm, providers earn more revenue. And one way that you can think about this just kind of anecdotally as being a thing is looking to the Dartmouth Atlas. right? So back around healthcare reform, Atul Gawande's cost conundrum really kind of put something in the public interest that a lot of health researchers knew for a while. There's just really, really large geographic variation in healthcare spending across the country. And so if you're not familiar, the Dartmouth Atlas is essentially collecting gobs and gobs of Medicare data, and they have documented that there are these big, big differences in utilization. And why can I say utilization? Because Medicare, by and large, is a fixed price that has some geographic variation, but these measures account for the underlying geographic variation in price. And also the Dartmouth researchers adjust for geographic variations in age, sex, race and ethnicity, so that the measure they're really trying to produce here is variation in the volume of care. And then the connection here is the thought that historically fee-for-service reimbursement in the Medicare program, whether it's the DRG payments for hospitals, RVRDS payments for physicians, inherently fee-for-service and inherently kind of contributing to this wide geographic variation in the volume permitted by this payment model. So there's some hope for optimism in the sense that, yes, on average, we can probably say that the level of healthcare spending in the US is high because we have suboptimal ways of paying providers, but we're kind of inching towards improving those payment incentives. And so one example is the big, big change that happened to the number of days that patients spent in the hospital back in the 80s when Medicare switched from something called cost-based reimbursement, which is basically tallying up every single thing that happened in the hospital and paying for it, to switching to a diagnosis-based reimbursement strategy, which was, okay, we'll make a payment based on a diagnosis, but it's going to be a fixed payment for this admission, and it's not going to be higher when the patient stays in the hospital like an extra day or two. It's not going to be higher when the hospital provides additional tests, right? Kind of this notion of moving from a variable payment that covers everything to a fixed payment is inherently the direction that a lot of these new payment initiatives are trying to tackle, right? So again, thinking about the bigger picture of this in 40 minutes or so talk, suboptimal payment levels, a big reason for why healthcare spending is high. We've seen some successes in moving towards alternative payment models, and the hope is that some of these more recent attempts, like bundled payments, accountable care organizations, MACRA, the new healthcare reform has kind of introduced these value-based modifiers to the RBS fee schedule, comprehensive primary care plus, all little efforts led by Medicare, which presumably a lot of private health insurance or plans are kind of following, is in large part really trying to move this suboptimal payment approach to being a little bit better. Okay? We can maybe talk about some of these concrete examples later. Big picture here, the third thing to kind of talk about in terms of motivation for high levels of healthcare spending, relatively limited market competition in the healthcare sector. So I'm going to break my first rule and deviate a little bit from focusing on levels and talking a little about changes over time. But the main message from this slide is to say a few things. First off, the level of market concentration, which is essentially the antonym of market competition, right? The level of market concentration, the extent to which a couple of players are dominating market, it's arguably high in the healthcare setting, right? So 1,500, which is the bottom here, is the Department of Justice's and the Federal Trade Commission's benchmark for thinking about when healthcare, or when markets in general are competitive. HHI measures below 1,500 would be competitive markets. And as you can see here, whether it's physician markets, insurance markets, or hospital markets, on average, they're either moderately or highly concentrated. Right? Hospitals being the worst, right? Primary care physician markets being a little bit more competitive than specialty care physician markets. That's hopefully kind of intuitive. But a quick departure to think about the levels, like this is not something that's necessarily getting better over time, right? It's not like we're creating more competitive healthcare or health insurance markets over time. In fact, it seems like things are getting a little worse in terms of increasing market concentration, right? So it's been relatively level for insurers, but that's not because they didn't try, right? So several years ago, there was talk about the big five getting narrowed down to the big three, right? But eventually, when the dust settled, the companies involved decided not to proceed with these mergers. And so we still have relatively concentrated health insurance markets, but not necessarily as concentrated as they could have been had these mergers actually happened. Okay? So it's a little more complex than I just described because this is showing averages, but if you look across the country, like the averages aren't necessarily like that informative because there is just a ton of variation across the markets in the US in the extent to which there is insurance concentration here on the x-axis or hospital concentration on the y-axis. So each dot here is essentially an employer in a nationally representative employer survey that my colleague Aaron Trish and I examined the effect of the interaction of these two things on premiums. And so what I'd like to do is kind of walk you through this intuition about this interaction between hospital and insurance market concentration. But again, after starting off with the point that like, it's just a ton of variation, right? Like, circumstance here in Las Vegas is going to be different than the circumstance in Baltimore, than New York. And so the way these things interact and the relative levels will be pretty important. Okay? So the first thing to do before talking about the interaction is to kind of make this comment again about how we just really don't have competitive healthcare markets in the US. Okay? Again, the Department of Justice and the Federal Trade Commission view an HHI, a Hirschman-Herfindahl index of less than 15, or really 1,500, this is normalized, divided by 100, as being competitive, right? So markets in the US that are down here, below the red lines, are the ones that are considered competitive by federal government and economists, right? It's like 2.5, right? If you maybe get a little bit more of a liberal interpretation and say, well, maybe healthcare is a little different, let's think about a measure that's 2,500, right? Those are the yellow lines. And certainly you get more markets in the US that are moderately competitive, but still, vast majority of markets in the US characterized by heavily concentrated hospitals, heavily concentrated insurers, or both. Right? And so there's a little bit of a twist I'd like to argue here that happens when you think about the interaction here. Okay? So let's start off by thinking about the lower left corner, where it's the benchmark that rarely occurs, which is competitive hospital markets, competitive insurance markets. And the thought here is that the competitive markets get relatively low prices, provider prices, particularly for hospitals, but you can take this same logic and apply it to physicians. And then overhead, right? So overhead would be the extent to which the insurer pays out claims and then tacks on administrative overhead, particularly their profits, and charges a premium to employers and people in the individual market. Okay? So what happens if you try and kind of like hold hospital market concentration fixed and still assume hospital markets are competitive and add insurance concentration, right? Well, what happens there is that the prices paid to the providers don't really change that much because they were arguably competitive in the first place. But now the insurer, with this added market power, has the ability to charge higher profits, and the administrative overhead is higher for that insurer. Okay. Relatively straightforward, I hope. What happens instead if you move along this dimension, right? Hopefully relatively straightforward as well, which is if you have a competitive insurance market, and that stays the same, but the concentration level in the hospital market increases. These hospitals then use their increased market power to increase prices, and the insurers just have to pass that along in terms of higher premiums. It's this last one that I'm kind of leading up to, which I think is like the most interesting, because what happens if you have high prices due to hospital market concentration, but then actually move to a situation where you actually have high insurer concentration, right? Then you have this bilateral negotiation where now the insurers have this power to be on the opposite side of a table than a high market power hospital, negotiate prices down, but not necessarily pass those along to consumers, right? They can negotiate the prices down, but actually capture those as higher profits. And so circling back to here, right? Was it the case that when these proposed mergers were going down, like was there a bunch of consumer advocates like storming Capitol Hill, going to the hearings and saying, oh, we gotta block this merger because it's gonna be really bad for consumers? Like, no, not really, right? What happened is that the AMA and the AHA were the ones that went to Capitol Hill and said, you gotta stop this merger because it's gonna be bad for consumers, but it's gonna be bad for us, right? They're gonna be paying us less when they merge. Okay. Additional thing to say is, like, I've really just kind of focused on the price, but some new research I've done both with Aaron and then another colleague of mine, Carolyn Hansen, is to kind of look at this same dynamic of thinking about insurers and hospitals negotiating with one another, and thinking about the contracts that result, and instead focusing on hospital quality, right? And so essentially we see kind of the same story, but perhaps with a neater figure that kind of argues that hospital quality is probably the highest when the hospitals are competing with one another, right? But there's also this concentrated insurer that has the strong power to get them to compete even harder for that insurance contract, right? And so as a result, right, there might actually be some benefits to having relatively concentrated insurance markets, although not here, okay? So what this is showing is the relatively concentrated health insurance markets in the exchange, right? So these are essentially not showing HHIs, but the number of insurers that exist in counties across the country in 28 in the health insurance exchange. And so as you can see, like in 2018, half of counties either had one or two insurers. Right? Advocates of the ACA were like, well, we'll start these exchanges and maybe they'll start off a little sluggish, but competition will increase over time. And that's actually not what's happened, right? If you look at 2014 and the number of insurers that were operating in the health insurance exchange, at the time in 2014, we thought this was low, and we were kind of bummed out that it was low, but we were hoping it would get better, and no, it actually got reversed, right? Because a lot of the insurers that we were hoping would enter into the exchange didn't, and some of the insurers that did enter into the exchange were just like, forget this, like this is a small market, like what's the point, why are we even doing this, okay? And then to pour even more cold water on this, right? This whole stuff I talked about earlier about, well, insurers having some power and be able to negotiate lower provider prices and increase hospital quality, like, that's not actually happening here from the concentrated exchange markets because they're just such a small fraction of the overall patient volume that what really matters is the volume in the employment-based market, right? So when you have these concentrated health insurance exchanges, you're just really kind of getting the harms from the lack of competition in the insurance market and not really getting any of these benefits that accrue from the insurer's concentration. Okay. So again, to hammer this point home, a third big thing in terms about the levels is limited market competition in healthcare markets. Pretty clear that higher healthcare spending results from hospital concentration. Other literature clearly kind of documenting that there are higher physician prices from physician concentration, but kind of interestingly, unclear effects from insurer concentration. And the unclear isn't really a story that we benefit overall on net from insurance concentration. It's really just kind of like, well, it may not be so bad because they'll at least get these lower provider prices. They're not passing them on to us, but at least they're not increasing their premiums further. Okay. So, policy proposals, just briefly to kind of hit on that are related to this, like in the absence of doing something more directly to try and improve the amount of competition. In the ACA, we've had these minimal medical loss ratios to try and limit the administrative overhead that insurers charge. In hospitals, I'll mention this because it's a big thing where I am, which is Maryland. We've actually had rate setting since the 70s, right? A couple of other states did it in the 70s, but only Maryland stuck with it. Not clear whether that's a good thing or bad thing, but it's a thing in Maryland. And that rate setting, right, arguably kept payments low because it was the government enacting those rates. And finally, like I've been kind of remiss not even mentioning pharmaceutical drugs yet, but clearly a lot of what we see in terms of high prices for drugs is arguably connected to a lack of competition in the pharmaceutical drug market, right? So some of this is clearly that we're not having adequate competition in the generic drug market when there should be. But arguably, the lack of competition in the brand name drug market is by design, right? That's what we've kind of set up in terms of the patent system, in terms of trying to give these drug companies incentives to innovate. Okay? So again, to summarize these three big things, certainly lots of other reasons at play for why high healthcare levels of spending exist. These are my top three. Debatable, right? I mean, certainly others, but like, if I'm going to choose three, like, these are my three. Let me transition to talking about rises in healthcare spending. Okay, and so again, to kind of motivate this, circle back to this nice spaghetti figure from the beginning of the talk, showing high healthcare spending in the US compared to these other countries. But to emphasize two things, right? Here in the US, right, our current high level of healthcare spending is partly attributable to our historic high growth rates in spending, right? The slope of the purple line much steeper than the slope of these other lines, okay? That's one main message. The other main message, though, is a lot of what I want to talk about in terms of growth in healthcare spending isn't unique to the US, right? All of these other countries are also grappling with similar issues with respect to high growth rates in healthcare spending exceeding the growth rate in their economy. Okay. I like this one. It's pie charts for healthcare healthcare spending. So first off, what economist doesn't love a pie chart? But more to the point, right? I think trying to illustrate a couple things. Like, so one is that I've scaled the size of the pie chart to reflect the percent of healthcare spending as a fraction of the economy, right? For 1975 relative to 2014, right? That's basically pi r squared kind of stuff, right? The other thing is, like, the data from CMS, right, is kind of nice because it shows how healthcare spending is divvied out for hospitals, physician, drugs, dental, long-term care, other, and administrative. And so you can see, right, how the composition has shifted a little bit over time, right? So first off, every sector has encountered growth, right? The slices of pie on the right-hand side are always bigger than the slices of pie on the left-hand side, right? In terms of volume, right? But some places have seen average growth, like physicians, right? Stability at about 20% of all healthcare spending, whereas other sectors, namely the hospital sector, has experienced relatively lower growth in healthcare spending. Whereas other sectors, namely pharmaceutical drugs and also administrative costs, right, experiencing relatively higher growth in spending. All right. So let me talk a little bit about some of these explanations for high healthcare spending. I've already kind of given my main punchline, which is I think it's largely, not I alone, right? Most of us argue that it's largely technologies that are responsible for high healthcare spending, but I want to highlight some other ones that are important as well. But before doing that, I want to kind of make a point, which is to distinguish between shifts in spending from private sector to public sector compared to just overall increases in spending, right? Bless you. And try and talk about how insurance expansions do or do not play into some of this, okay? So one thing thinking about the growth in healthcare spending is that, well, we have a whole lot more Medicare beneficiaries now than we used to, right? Part of that is population growth. But a large part of that is increases in life expectancy coupled with a fixed retirement age of 65. So that in turn, what we get is something that's kind of a little bit maybe more meaningful, particularly on the finance side, which is thinking about workers per beneficiary for the Medicare program, right? How many people are we essentially taxing right now to cover healthcare spending for the people on the Medicare program, okay? This is really important in terms of public finance, and I don't want to minimize that. But if you think about the bigger picture perspective of healthcare spending in the US, right? Shifts from private insurance to Medicare at 65, like probably not really a big thing, right? They had insurance before, they had insurance after, like their levels of healthcare spending maybe changed in a little bit because Medicare tends to pay providers a little bit less than private health insurance plans. But in the big scheme of things, right, aging of the population, people moving from under 65 to over 65, probably not really a huge impact on overall healthcare spending as a percentage of the economy. Okay. That said, we have set ourselves up with a bit of a problem where we haven't been taxing people enough relative to the amount of benefits that people are receiving in the Medicare program, right? So I'd be remiss in not talking about this notion of workers per beneficiary by not also trying to show some of this data. And I don't want to make a policy-oriented claim that taxes have been low or spending has been too high, right? Because political preference probably influences how you think about that. But I'll just make the statement that there's an imbalance in the sense that the benefits people have received through Medicare historically have largely exceeded the taxes they've paid into the system. Right? So you've got different scenarios of single beneficiary, 100 couple, 200 couples. The different gray bars are whether they had low income, high income during their working age. But again, the main message, there's a disconnect here. Okay? The other thing that arguably may not have the biggest impact on overall healthcare spending, but is still important to talk about, is the expansion of the Medicaid program. Right? So Medicaid has grown considerably. This is showing not numbers of people, but percent of the population covered by Medicaid since its introduction in 1965. And it's much, much bigger now than where it was before. You can talk about like several expansions over time, the CHIP expansion, the ACA expansion, more recently, the expansions in the 80s to more women and pregnant women and children. But by and large, we've had a big expansion in the Medicaid program. And I want to distinguish what's happened with the Medicaid program from the Medicare program, right? Because this story, right, people switching from private insurance to Medicare, like, is by and large a little bit of a wash when it comes to healthcare spending, because the vast majority of them had health insurance coverage and not a lot's changing. When you move from having people largely uninsured to getting Medicaid, right, that is having an increase on healthcare spending. And we arguably largely think about this as a good thing because we worried about their poor access previously. But these insurance expansions, kind of transitioning from self-pay to public pay, arguably having an impact on rising healthcare spending. And one way you can alternatively kind of think about this in terms of some crude statistics is really just looking at what percentage of total healthcare spending in the US is paid out of pocket, right, versus paid by insurers, right, either private or public. And state can kind of be thought of here as an insurer. Again, like on one hand, we think about this reduction in out-of-pocket healthcare spending as in some sense, many respects, being a good thing because we want to have people exposed to less risk, variation in their healthcare spending. That's a concern. Insurance is a good thing. But arguably, you could have too much of a good thing, and exposing people from risk also means that they pay lower prices for their healthcare and go more often. And the research kind of suggests that when they go more often, it's not necessarily the case that the healthcare spending has value. So, again, just trying to think about where I am in terms of like the overall big picture here. Talked about explanations of high level of spending. I'm now kind of focusing on the growth in healthcare spending, and in some respects trying to acknowledge but minimize some of the commonly cited reasons for the growth in healthcare spending. Like aging, not really. Health insurance expansions, yeah, probably that's led to increased healthcare spending over time. Rising real incomes, right, that's probably also led to increases in healthcare spending over time. That one gets a little touchy because when you admit or acknowledge that healthcare spending increases as your income increases, that's essentially an argument that healthcare is more like a luxury good than a basic necessity, right? And so at the School of Public Health, everybody loves to talk about healthcare being a fundamental right. And if that were the case, we would expect no real relationship between healthcare spending and income, but we clearly do. Increased chronic conditions, we, including myself, right? We are obese, right? And the extent to which we haven't increased the percentage of the adult population that's overweight, right? So look at that, it's actually stable. That's just because we're just becoming way obese, right? Kids, a similar situation, right, shown up top. And then in turn, right, if you think about all the things like high blood pressure, diabetes, like, you know, all the different conditions that are linked to obesity, and then in turn, the increased healthcare spending attributable to these conditions, notably obesity, certainly an explanation. Okay. And so, right, to try and bring this all to a close over the next 4 or 5 minutes, healthcare spending, high in the US, right, rising in the US, and rising higher in the US than these other countries. And you could say, well, if we're at least getting healthier than these other countries, like maybe it's all worth it. You look at the US is shown here in red relative to these other OECD countries for life expectancy, right? We are not keeping pace with these other countries, which I think is consistent with the fact we have a very fragmented and inefficient system. But I'm an optimist, right? So the fact that it is increasing, that's something, right? So, the last thing to kind of end on is like, well, like, if you think about over time, like, what are we spending our money on, like, over time, right? Well, joint replacement procedures, right? Hip replacements, total knee replacements, these things are expensive, they're real technologically savvy, but arguably getting a knee replacement improves quality of life. It happened to my dad. Very happy to have received his artificial knee. Similarly, we've done a lot in technological advances to treat heart attacks, right? So old study, but a very seminal study by a couple of big players in healthcare that essentially noted, like, look, we've done a lot in terms of technological invasive advantage procedures to treat heart attacks, wrapped it all together and kind of said, look, over time, it's cost about $10,000 more to treat somebody with a heart attack in 1998 relative to 1984, but also ran the numbers and saw that people who had heart attacks in the Medicare program had a 1-year increase in their life expectancy. And when you run the numbers and try and tack some estimates of what you'd be willing to pay for that 1 year of additional life, pretty much exceeds the additional $10,000 that was spent. So I mentioned MRIs and CTs earlier. Like, here's some data showing both the growth in these technologies over time and also showing where we are relative to the other OECD countries, right? So this is for CTs, this is for MRIs. And I guess the main thing to kind of conclude on, right? Yeah, there's these other reasons, mostly due to new technologies, but a lot of these studies of the growth in spending attributable to technologies conclude that it was worth it, right? Consistent with that kind of Cutler and McClellan paper I showed for heart attacks. Like, there's a large body of literature that says, on average, the new technologies are worth it. Okay? But, right, there's a big but here, right? But, right, even though it's great that we have MRIs in the US, CT scanners in the US, right? No one would ever say, oh, we just never should have had an MRI invented in the first place, right? The challenge is once we've got them, we use them, right? We plug patients through them as quickly as possible due to the underlying incentives of the healthcare system. And so that in turn, to kind of conclude, the key for policymakers is to try and develop smart policies that are, I think, personally, are like permissive of rising healthcare spending that we value, right? But try and do things to minimize spending at a point in time that we don't value. Okay. And so with that, thank you for your time. Thank you for the great weather and look forward to your questions a little later. Right?
Right.
Okay.
thank you for getting us off to a great start. We will have time for questions after this next talk. Professor Chris Robertson comes to us from the University of Arizona College of Law, and he's really distinguished himself as a leading scholar in field of healthcare and law. He does great empirical research, comes up with a lot of innovative ideas, smart and innovative. He's a prolific writer. He has a book coming out this year, Expose, How Our Healthcare Insurance is Incomplete and What We Can Do About It. And I haven't seen it yet, but based on what I've seen of his writing, it's going to be very thoughtful, provocative, and very well worth reading, and hopefully we can get him back to talk about that. He's going to follow up. We've heard why we've got problems, and now Professor Robertson's done a lot of studying about some of the approaches we've taken to address healthcare spending, what works, what doesn't work, and that's what we're going to hear from. And then after his talk, we'll have a joint Q&A. Thank you, David.
It's really my honor to be here. You probably all already know this, but David is a real giant in our field of health law. And it's a real honor to come and speak here, and a real credit to your law school to have him here. I was excited to learn he joined you just recently. I kind of feel like we're sister colleges because you left out the full name of my law school, the James E. Rogers College of Law. So I think we have a deep connection from just being neighboring and our benefactors. So I'll be talking about strategies to drive value in the U.S. healthcare system. David set me up to try to talk about the solutions that are available. But to think about what are we trying to drive, I want to start with a working definition just so we can be really clear. When we're thinking about value in healthcare, we're obviously thinking about some benefits, typically reduced mortality, reduced morbidity, less pain, less suffering, more satisfaction. And these, of course, need to be measured, typically, if we're going to figure out what value is. We have to figure out some way to observe. Life and death's pretty easy to measure, but other things are a bit harder. But that's what we're talking about when we talk about benefits in healthcare. And I'll notice this is often, to the extent we can even talk about it intelligently, it often depends on some very concrete science. We have to run a randomized trial on a particular chemical compound to see what it does in the body at a specific dose for a specific disease. I'm going to come back to some of those, what I call epistemic challenges, which I think are pretty fundamental. Other things are sometimes easier to measure, like we're going to net out the costs, how much we pay for the healthcare intervention. At the same time, we'll also be worried about the risks and side effects of the intervention. You know, if it's in fact causing 1 out of the 10 people that take the insomnia drug to fall over dead, you'd want to account for that in your assessment of the overall benefits. So really, benefits net of costs and risks are what we can talk about when we're thinking of value in healthcare. And I want to suggest there are 3 broad focal points for thinking about value. One is the provider. Here I'm thinking of physicians and other practitioners, including nurse practitioners and physician's assistants and prescribers more generally. We think about the patients and the patients who decide for themselves, as well as the surrogate decision makers, the parents that decide for their child, or the adult child who decides for their parents. So the patient is a driver of value potentially. And third, and I think actually most interesting at a law school, are what I call the system factors of value. Things like, how do we produce knowledge about what is safe and effective? What about the conflicts of interest that are driving our insurers and our providers? They're much more fundamental than any particular decision process. And lastly, some of the monopolies and unregulated prices that we heard about earlier. I'm going to suggest these system factors ultimately are pretty important. But first, let's delve in a little more concretely. There's actually been some great research in some of these areas. This is a systematic review by Kala and colleagues that came out a couple years ago. And they reviewed the entire literature trying to find interventions that could drive value in our healthcare system. So I thought this was probably most responsive to the task David gave for me today. And they actually, in the entire literature on health policy, there are dozens of journals, thousands of publications, and it goes across this range of areas from patient cost sharing through clinician education and provider feedback. But ultimately, they only found 84 articles that they could credit as being methodologically reliable to produce any estimate at all as to whether something is effective, uncertain, or ineffective. And you can imagine we could spend an entire hour talking about any one of these 84 studies, but instead I'm hoping to synthesize for our benefit, but with apologies. But you can see one category here is patient-focused interventions like patient cost sharing, patient education. They're talking about like putting up a poster in the doctor's office or creating a pamphlet or maybe having a video a patient can watch. What you can see in this area is that there's been relatively few studies actually. And they're actually kind of mixed in their results. Some look effective, some look ineffective, a bunch look uncertain. This domain of driving value through patients is not well proven, and the results are kind of mixed, although there are some green bars suggesting some efficacy. Of course, each of these studies is very particular. It's a particular intervention that we're synthesizing over here. But similarly, you can look in this other domain of really focusing on the healthcare providers, largely the physicians, and you can see huge numbers of studies in comparison, almost all effective. You don't see any blue bars there. It seems like a stupid color coding to me, but the blue means ineffective. You see none of them in that domain. So every time they've studied it, they either find a positive result, gosh, this works to drive value, or maybe a shrug because the p-value ended up being a bit too big sometimes. Okay, so let me give you a couple examples to pull out of this literature to see what we're actually talking about. And I'll start here on the provider side. So this is a study by Baer and colleagues that came out a couple years ago from the Intermountain Health System, which is a fascinating creative health system based in Utah that works across western states. And they were interested in this problem, and like I said, these are very granular sorts of issues, but here's one of them. The problem is that they looked in their neonatal intensive care units, and they found a bunch of babies getting blood transfusions that it appeared were not appropriate for them. Now think about that. You're taking a helpless little infant, neonatal, and you're pumping someone else's blood or platelets through them. And when you go back and look at the science, it suggested that actually that wasn't a good idea after all. And not only that, that's actually a pretty expensive healthcare intervention. It costs a lot more money to do a blood transfusion than not. Some of these babies were getting 8, 9, 10 blood transfusions, and they were not supported by the evidence. And so here's one of these where I have to like wave towards getting into the weeds. If there's a doctor in the room, you can explain when blood transfusions are appropriate or when they're not. But these are the sorts of guidelines that we actually need if we want to drive value in healthcare. This is why we have physicians to interpret these sorts of technical information. But it's also why we have scientists producing these precise estimates for the physicians. So you can basically see, depending on the situation, you have to have a certain blood platelet count, and if it's below a threshold, then transfusion is indicated, but if it's above a threshold, the best science that we have at this time suggests the baby's actually better off without the blood transfusion. So this is just an example of what I mean when I say 35% of the blood transfusions were inappropriate. You'll just have to, take the background literature for granted. So when you think of the various solutions that could be used for this problem, imagine one patient-focused solution. Imagine we said, well, why don't we just impose on those parents an extra $1,000 copay every time their baby gets a blood transfusion? So I would think about how that would work in practice, right? The doctor would say, I think you need a blood transfusion for your baby, but it's going to cost you an extra $1,000. How are you supposed to know as a patient, well, that's a good idea or not? I don't know about you, but if my doctor says your baby needs a blood transfusion, I'm going to say yes, right? I'm going to say, okay, please do it fast. I have no idea. I don't know what that last table meant, but the doctor does. That's why I'm there. So instead, in this case, they tried a different intervention, but here it was to require that every blood transfusion that happens in our hospital system has to be ordered through our electronic health records system. You have to actually put it into the system. The nurses won't go get you the blood unless it's in the system. They won't wire up the system unless you put it into the electronic ordering. And we're going to write that computer program so that it bugs the doctor. The doctor cannot get past that splash screen without clicking which clinical criteria given by the guideline is satisfied here. They have to say it's the patient is above, the 5,000 platelet count, and it's urgent. Da da da. If the physician doesn't fill out all the blanks, it says sorry, no blood transfusion for your patient. There's ultimately a escape valve at the end. The physician can hit other and explain his reasoning, and if he does or she does, of course, they allow the blood transfusion. But the idea is to put the physician into a structure that puts some hurdles in front of the physician to jump through. And then the second step of the intervention was administrative reporting. We're going to issue a report to these physicians and the neonatal care director every month as to whether you've hit the benchmark that 100% of your blood transfusions need to be on guideline or have a good explanation of why not. And so it worked, actually. The number of blood transfusions in their hospital system went down substantially over the study period. A lot of these studies, by the way, I'll say, they don't have good control groups, they're not randomly assigned, but when the effects are substantial, we can make conclusions from them. But of course, would worry if they're just doing fewer transfusions, you could be throwing the baby out with the bathwater. You could be having babies that needed transfusions not getting them, so you want to actually notice if they're tailored or not. And thank goodness they found that they were, in fact. The vertical axis shows you what percentage of the transfusions are meeting the guidelines, and you can see by the end of their study period, they hit their 100% mark. They got rid of those 35% of transfusions that were wasted, and so there was a success. So we'll count that as a positive result. The health system went on to calculate that they saved over $750,000 in that first year alone. Of course, that's not going to solve all the healthcare cost problems in the United States, but I want to illustrate that these battles are often fought at a very granular level, patient by patient, hospital by hospital, procedure by procedure. And so you would have to imagine, could we do a similar intervention for not neonatal blood transfusions, but artificial hip surgeries, and et cetera, et cetera. But this at least suggests an example from the literature of how managing doctors can actually improve care, at least as our scientists tell us it should be, and save money on debt. Another asterisk to put on this is to ask, why was this health system wanting to save money? Couldn't the health system have just billed for all those extra transfusions? That asks some larger questions about how the health system's being reimbursed, whether they're integrated with an insurer, etc. Sometimes the difference between a managed care integrated health system versus one that's paid per procedure. But this gives you a sense of what can work. I've written on this broader strategy of putting hurdles in front of doctors, and it's something that's been called rationing through inconvenience. And those are almost ugly words. I don't know if you've seen this book by Sandeep Lahar. He compiles a lot of the statistics to say doctors are now spending over an hour a day on paperwork. If you go into the doctor's office, you don't see the doctor. Instead, you see the back of his tablet because he's typing on it the entire time rather than looking at you and talking to you about your care. 94% of physicians, the opposite of the 6% here, are happy with their morale as a physician. Only 6% say, yay, thumbs up, I love being a physician, in big, robust surveys. And most of them tell their children, no, I don't recommend you become a doctor, at least not in the United States. It's not a good practice to be in. Now, on one hand, who cares, right? I mean, they're here to serve, they're here in our economic system. Our goal isn't necessarily to make them happy. But if this rebounds to healthcare costs and makes it more difficult to achieve our healthcare goals, we should care. Do we have any healthcare providers in the room? How many of you basically agree with this? Is it worrisome? 2, 3, 4? Yeah. Well, this is the great article from 1989, Joe Grimet. I don't usually like to read a slide, but he's so powerful in explaining this notion of rationing healthcare through the inconvenience. He says this is the slowing and controlling the use of services by impeding, inconveniencing, and confusing providers and consumers alike. It consists of superseding the physician's autonomy by a managerial review process in which armies of claims clerks, administrators, auditors, form processors, peer reviewers, functionaries, and technocrats of every description insinuate themselves into a complex system that authorizes, delivers, and pays for medical service. And a few years later, my friend Donald Lai wrote that rationing through inconvenience it includes rejecting claims in whole or in part for procedural or technical reasons, making the claims process and its rules extremely complex, and ultimately inducing claimants to give up. So in this paper of mine with co-authors Nir Eyal and Paul Romain, a philosopher and a physician, seems sort of like a joke what happens when a philosopher, a physician, and a lawyer walk into a bar while they write this article. But we did some empirical analysis on some prior published work, and I want to break it down to you to look at how these sorts of rationing through inconvenience actually work. They are another solution. We use them every day in our healthcare system. So this data set from Teagarden et al. In a 2012 paper covered 38,000 cases where a pharmacy benefits manager had received an application, to access an expensive specialty drug off-label. I'll talk more about off-label later, but it's basically where the FDA approves every drug and device. Not generally, but they approve them as safe and effective for a particular use. So you might get a drug called Avastin for colon cancer, but your physician might nonetheless want to use Avastin for breast cancer off-label for another purpose. And there's interesting legality as to why that's allowed. Basically, the old theory was the FDA couldn't regulate the practice of medicine. That was for the states. So when the physician prescribes off-label, that would be regulated by the states, but in fact it's not. So physicians frequently prescribe off-label. This pharmacy benefits manager, a PBM, is a middle person between the insurance company and the patient. Their job is to help reduce wasteful spending, and so they set up a pre-authorization system. Pre-authorization is saying, we will decide, we the PBM will centrally ration this highly expensive care. We'll decide whether the patient gets it, so just send us an application when you want to use a drug off-label. And so this graph, I've tried to represent each of those cases with an icon here of a person, so each one represents 1% of the 38,000 applications that were submitted over a year. One thing I want to note, though, is that there's this other population of patients that we don't see in this data set because their physician thought about that process of filling out the application and went, maybe we'll just try the on-label drug. So those people who were actually deterred from even applying for the drug is another effect of this rationing. And I don't know how many are there. It might actually be 3 or 4 times as large. It might be 10 times as large as the patients who were deterred, the ones that were deterred from even applying. But if we look back at the ones that did apply, of course, here the physician actually suffers the inconvenience, spends the time to fill out that paperwork. Let's see what happened to their applications. In fact, the PBM accepted those applications 90% of the time. They said, okay, sounds like a good reason. You think this patient isn't a good candidate or they've already tried something else, fine, you can use the drug off-label, we'll reimburse it. For the other 10% of the cases, the PBM actually said, no, I'm sorry, your patient can't get the drug. But it doesn't stop there. In fact, then, in 6 out of 10 of the cases, the physician says, okay, I'm going to stop at that. We'll go back to the unlabeled drug. Even though I thought it was the right thing for my patient, if you won't do it, fine. But only in 4% of the cases does the physician now double down and go through a second layer of inconvenience and fills out the appeal paperwork saying, no, wait, this is actually really important for my patient. And 3 out of 4 of those actually succeed. So what I want to illustrate here is that in this huge system that we think about as centralized rationing, that is actually only applying to 1% of the applicants in that. In fact, the vast majority of cases, what we normally think in this case as centralized rationing, is rationing through inconvenience. It's using this large, complicated system to reduce healthcare consumption. And it's largely doing so on the backs of the time of the physicians taking to do that. It does seem to work. Those other cases go away. They don't consume. That's 7% of the cases we've knocked out by instead causing 30,000 people to fill out the paperwork. So more here in my paper about sort of the ethics of doing so. How should we think about rationing through inconvenience versus cost exposure, for example? How should we think about it compared to true cases of centralized rationing? One of the interesting things to think about here is it actually creates a conflict of interest because it's the physician's time that's going to be inconvenienced in that case, but the patient's access to the drug. And so it really is, we can think about also the disparities involved there. Who's likely to have the patient, the physician that's going to advocate on your behalf? So there's a whole realm there to study further. But that gave you a flavor of provider reforms as a mechanism for driving value. Let's talk a bit about patient focal points for value. Standard theory that we saw some echoes of in our first talk today of moral hazard is that there's a problem with health insurance. Because health insurance allows patients to decide whether to consume health care, but the insurer is the one that pays for it. So anytime you have this separation between receiving something and paying for it, it creates this potential problem of moral hazard. In fact, our President Donald Trump has said there's nothing like doing things with other people's money, OPM. And he's done things with other people's money in lots of different ways. But moral hazard in health insurance is one of them. So the problem here is that at the point of sale, the fully insured patient says, I don't care whether this drug is worth $1 or worth $10,000. It's free for me either way. I'll take it. And you see this theory being hugely influential in mainstream economics. Kenneth Arrows, this Nobel Prize winner, wrote about it in 1963. Mark Pauly, still one of the leading voices in health insurance today, talks about how it's a leading cause of waste. Richard Zuckhauser, a Harvard health economist, similarly saying, this is fundamentally a flaw in health insurance. And some of these scholars even suggested that health insurance may do more harm than good. The wasteful spending caused by health insurance might actually destroy more welfare than it brings. So the solution we've seen in health policy is what I call incomplete insurance. We say, okay, we can't just shut down all of insurance, so instead we'll make it incomplete. We'll make patients pay a portion of their health care. We see this in deductibles and co-pays and co-insurance and reference prices, which I'll talk more about in a moment. All of these are essentially the absence of insurance. They're saying that for a portion of your care, you'll have to pay yourself instead of getting it paid by the insurer. And so that's this notion we're going to take out a part of the cost of the treatment and make you pay for it. And I want to distinguish, it actually has two different functions that I think are sometimes not obvious. The clearest function is you think, this is the part that I'll have to pay for my care. But the other part is actually, the goal is actually not just to distribute the costs of care, but to cause some incidents of care to not happen. You want some patients who feel that weight of expense to go, no thanks, don't give my daughter the transfusion, or no thanks, don't give me the artificial hip because I'm exposed to 20% of the cost. And that behavioral function is really the one that economists are primarily interested in. I just want to emphasize how extremely influential this has been. It's written into fundamental economics textbooks. James Kwok, I suggest this book to you. It's called Economism, how policymakers have also taken this like nugget of wisdom in a very simplified form and used it to drive entire mechanisms of healthcare reform. Because it is beautifully simple, other people's money. And I'm going to do the risk of actually trying to play a video in here.
Your experience, why do these savings accounts, why are you pushing so hard for them? Why do you think they're effective?
Because you're spending your own money as opposed to someone else's. It's like when my daughter goes to the mall with my credit card, or when I go to the mall with my credit card. Our purchases come back quite different.
Okay, setting aside that healthcare is nothing like shopping at the mall.
Okay, I know you'd much rather hear what he has to say about this, but you can find him on YouTube. The point is, we also see this on the left. It's just almost become a notion of smart thinking about health insurance is to recognize the fundamental moral hazard problem. You'll recall Bill Clinton's reform of welfare as we know it. I mean, he also had the same notion that we need more personal responsibility for our own health care costs. And accordingly, we've seen in the last decade alone a huge move to cost exposure. I mean, this is just from 2008 to 2018. You see deductibles growing at 10 times the rate of earnings or overall inflation and 5 times the rate of health insurance premiums. We're shifting more and more risks to the patients and their families and spending less of it through health insurance, partly due to this moral hazard notion. And interestingly, the Affordable Care Act started to push back the other way, but ultimately in a very milquetoast sort of way. He says, we're going to put a limit on total exposures out of pocket, but the actual limit under the law is $14,700 per year for families. So in a given year, that's your worst case scenario under the Affordable Care Act in employer-sponsored health insurance. But in some of my analyses, you can look at, well, what would $14,700 actually do to people? And if you take the incomes that people earn and divide it into 5 quintiles, even the people in the middle quintile earn about $50,000. That's around the median of the United States. $14,700 would knock out a quarter of your income in that year. For people a little poorer in the second quintile, it would knock out 45% of their income. And so I suggest we still have huge cost exposures, potentially even under the Affordable Care Act. Thankfully, not all insurers have gone up to that limit. The limit is almost merely hypothetical because it's so extremely high. So the evidence suggests that cost exposure largely works. There's a phenomenal study conducted in the 1970s called the RAND Health Insurance Experiment, where they actually took thousands of people and randomly assigned them to different health insurance policies. Some had 100% health insurance coverage with no cost exposure. Others had progressively larger cost exposures in a range of conditions. This has become almost a key insight for health policy, is that the people that had full insurance coverage spent more on their health care. As you expose them to more of their own costs, they spent less on health care. There were a few asterisks, though, that you may or may not think are very important. The first is that it cut that care completely indiscriminately. We had patients declining preventative care like mammograms that were really essential for them at their age, but also declining other care like extra antibiotics that they probably shouldn't have been taking in the first place. Now, notice for a second, I'm going to go back to my earlier theme, that all of this health care was prescribed by licensed physicians. And so across all of it, we were trying to get patients to say, don't do what that expert just suggested that you do. And so sure enough, patients would sometimes say, oh, okay, I won't do that. But it ended up being completely indiscriminate in the literature. And they also found, it turned out the study was not well designed or well powered to detect effects for the lowest income patients. It suggested that maybe there was some worse effects for them. And this was not, this was even though the study was designed with a peculiar form of cost exposure that actually gave each individual a cap adjusted to their own income. Much more precise than the cap we see under the Affordable Care Act. It actually protected people to some degree, but we still saw potential worsening effect for lower income patients. And finally, we also saw some worse effects for chronic conditions. Patients that were exposed to cost exposure would not necessarily adhere, for example, to their insulin or their heart drug for their, and this has been replicated in subsequent research over decades, that we see that cost exposure can actually get in the way of adherence to the drugs that we use to treat our chronic conditions. But the bottom line, I think, that health economists and health students take away is this one, is that it works, that you can reduce health spending without a lot of people dropping dead. It didn't appear that the ones who were reducing health spending were measurably any sicker or died any sooner. But they did spend less money. So count that again as a win for cost exposure as a policy solution. Some of the more recent research, this is from one of the top economics journal, came out just this year, or just last year, looked at a particular employer that imposed a lot more cost exposure all of a sudden. And the hope was that if we give our patients more skin in the game, they'll start spending more prudently, we can reduce health spending overall. And they once again found that patients didn't seem to behave like consumers. When they go for healthcare, it's not like they're going to buy a TV or a washing machine. Instead, they seem to be doing whatever their physicians suggest for them to do. And moreover, when they decline to do what their physicians tell them to do, they do it again indiscriminately, declining both preventative services and things that maybe the economists think they shouldn't have been consuming, like imaging services. So I'm just giving you this one more post-RAND study to suggest the general theme that cost exposure reduces spending, but does so indiscriminately and potentially harmfully for lower income patients. I do want to mention this other really novel form of cost exposure that's called a reference price, because I think there's lots of interesting potential here as a solution. For a reference price, an insurer looks at a population of providers and says, look, for orthoscopic knee surgery, for example, there are providers in your region offering it for $28,000. We will cover that $28,000 fee, and you can go there for free to you if that's the one you choose. But you might find that some other orthoscopic surgeon has a prettier office or a more convenient office or better word of mouth, and you're welcome to upgrade to any other one you want, but we're just going to pay the reference price. The cool thing that this mechanism does is it gives the patient complete exposure to the marginal additional costs. They bear 100% of those extra costs if they want to consume them, but at the same time it gives all the patients complete access to the base level of care. And so in a pretty rigorous study here in Health Affairs a few years ago, they looked at imposition of cost exposure through reference pricing in CalPERS, the huge employment health benefits program in California, versus another healthcare provider a health insurer that didn't implement it. And you can see in 2010 when they implement this change, all of a sudden, patients start going towards low-price hospitals in the CalPERS system where you don't see any big change in essentially the control group. You see, it allowed patients to price shop essentially for the price difference above the reference price, again, while guaranteeing their access to the minimum care. I also want to flag this other real problem of cost exposure more generally. But before I go here, I just want to mention reference pricing has been useful in some domains where you have this well-defined service like an orthoscopic knee surgery that's almost like a commodity. There's 15 different providers of it, and we can see their different price points. It doesn't work so well for blood transfusions or a lot of other hospital services or other things that require a lot of judgment that aren't just a commodity. But it's a cool thing to try in some areas. The other version of it you see is tiered pricing of pharmaceuticals. Sometimes you'll see in your own health plan that if you wanted to do the generic drug, you can get it for free or for $4. But if you want the brand name, it'll cost you 20 or 30. Same chemical compound. That kind of tiering can be thought of as a close analog to reference pricing, and it works pretty well. But as a much more general policy mechanism, cost exposure suffers from this big problem that's been known in the literature as underinsurance. We're all familiar with the notion of uninsurance, right? It was the big effort that Obamacare tried to solve, is to get more people insured. But underinsurance is the problem that even if you do have coverage, your exposure to costs might nonetheless be so high that it causes other problems for you. And this is going to be relative to the individual person, right? I mean, for me, having a few $1,000s exposure might well be bearable, but for someone else down the street, even a few $1,000s could put them into bankruptcy. So we have to figure out for each individual what's an appropriate level of exposure, and typically our health insurance plans don't do that. There's this huge literature on underinsurance. I'm just going to give you a flavor of it. This was a big study in the New England Journal of Medicine a few years ago by Kogan and colleagues, and they have a measure for what counts as underinsurance. You know, if someone has such high exposures that it would impinge on over 10% of their income and a few other factors, we can call them underinsured. And they found this huge rate, even among people with private health insurance, the good kind of health insurance. A quarter of the children in the study were underinsured. And here's the striking effect of it, is that when they looked at patients who were underinsured and compared them to patients who were truly uninsured and looked at some of the factors we think are good, like having a reliable pediatrician who'll pick up the phone when you call, they found the same problems across both populations. The patients that were underinsured were looking at their families like, wow, I can't take you to the doctor because it'll just be too expensive if we do. They're behaving just like patients that don't have insurance at all. So a few responses there were like, gosh, A, we might have a public health worry that the kids aren't getting the care they need. We also kind of should have a justice worry that someone's paying health insurance premiums for these families, whether themselves or their employers, in foregone wages, but they don't seem to be getting the benefits of health insurance. So there's another whole literature around underinsurance. I've done some work on people going through bankruptcies due to medical bills and foreclosures due to medical bills. But there's this larger sort of response to the moral hazard theory by an economist named John Nyman. This book and his theory hasn't gotten nearly enough attention. But his point is that maybe cost exposure made sense in the 1950s when, a doctor was carrying a black bag and would come to your house and would ask for $10 after giving you some care. But now aggregate healthcare spending is driven by these humongous expenses, orthopedic surgeries and heart stents and cancer drugs and transplants that can literally be multiples of your annual income. And he says insurance actually does something different there. It's not just protecting you against the risk that you would need to spend $250,000 this year, because you literally couldn't spend $250,000 this year. Instead, what insurance is allowing you to do is to purchase health care that would otherwise not be accessible to you at all. In that sense, it's like a joint purchasing association. And the data bears this out. That although, in our day-to-day lives, we think about, the $20 prescription that we fill, or the $500 broken arm, or the sort of ubiquitous healthcare, but actual aggregate health spending is driven by these huge costs. For example, half of all health spending in the U.S. is driven by 5% of the people who are unlucky enough to get sick in any given year. And on average, they're spending $50,000 in that year. And so when you think about health policy, how do we design cost exposure in a world where this is the kind of care we're trying to fund? There's really going to be limits to how much cost exposure we can use because patients just aren't rich enough. The ones that are unlucky enough to be the ones really spending the money, they're not rich enough to bear 10% of that in the bad year for many patients. So under this theory that Nyman asserted, yes, if you get more health insurance, you get more spending, but that's a feature, not a bug. That's really the purpose of health insurance in this domain. And we see this internationally, which I hope we'll talk about later. Across other parts of the world, we see more fulsome health insurance policies, but less health spending. Health insurance isn't the problem in that domain. So my suggestion around cost exposure is that we could largely just stop it. It's really the juice is not worth the squeeze. Is that the phrase? But it causes so many problems and distorts medical decisions so much. It's really been the wrong focus for healthcare reform too long. Yes, it cuts spending, but it does so indiscriminately. So a much simpler version might be to have someone literally take some dice and roll them every time you're going to choose healthcare and say, oh, you rolled a 12, no care for you. That's what cost exposure is doing, except it's actually discriminating against poor people as well. At the very least, if we're going to keep cost exposure in the U.S. system, we should tailor it to value. And by that I mean we should apply it in areas where we know the care is not helpful. Right? If for some reason you think the off-label prescription of Avastin for breast cancer is a bad idea, put the cost exposure on that, not across the board. Definitely remove cost exposure from things like insulin or heart disease drugs that actually promote and vaccinations, other things like that promote better health outcomes in the first place. And the second is you have to tailor it to ability to pay. Just like that feature from the RAND health insurance experiment that everyone's forgotten, we actually need scaled cost exposure according to income. So that lower paid individuals might at most be facing a few percent of their income in a given year. And again, if you look at other countries, they have radically lower cost exposure if they have it at all. So of the three focal points for value, I only have 7 or 8 minutes left, but I want to allude to what I actually think are the big important ones, and it's these system level factors that are driving, I think, real cost growth in the United States. And here I think there's really three. And interestingly, they're all economic problems that I don't think the field of economics has focused on as much, and the policymakers have definitely not drawn out of the field of economics nearly as much. And the first is the collective action problem of generating knowledge about what drugs and other treatments really are efficacious. The second is that our providers have misaligned incentives, some in the fee-for-service domain, but others as self-referrers. I'll talk more about it. And third, these huge virtual monopolies, either absolute monopolies or very close to monopolies because they have such concentration of power. And we're not actually using the widely known tools of what to do when there's a monopoly, which is price controls, just like we do in the utility service who provides our electricity, for example. So I'll just talk a little bit about each of these. The first is ignorance about efficacy. A CBO report is one way to cite this for you, is that estimates that less than half of all medical care is based on adequate evidence about its effectiveness. Vinay Prasad has done a fascinating book where he looks at when we do randomized studies about things that physicians routinely practice, they more often than not fail. Turns out to not be useful. But in many cases, physicians are really just shooting in the dark. They don't have a good scientific study to prove whether their care is on target or not. So I've already mentioned Avastin for breast cancer, for example. The FDA actually revoked the approval for Avastin, but we nonetheless reimburse. They revoked the approval for Avastin for breast cancer, but we nonetheless reimburse care for breast cancer under Avastin. Heart stents are another example, really important medical intervention for someone that's had a heart attack, but they're also widely used prophylactically before anyone's had a heart attack, and the evidence there suggests that it's a huge waste. Both of these are examples of off-label use. 20% of prescriptions are written off-label, according to the peer-reviewed literature. So 1 in 5 cases, that means the FDA hasn't actually approved and looked at whether there's well-controlled trials supporting safety and efficacy for that use. And more recent work has suggested that in those cases of off-label use, 80% of the time there's not good scientific support in favor of it. So that ignorance story is really about a collective action problem, because none of us, like if I get cancer tomorrow, can I figure out which chemical compound is going to cure my cancer? Of course not. I can't figure it out. I'm relying on larger systematic factors to do so, and that's why we require the Food and Drug Administration to approve any new cancer drug before it comes on the market as being safe and effective. But we need to do much more of that. And use it, and we need ways to ensure off-label drugs are brought on label. Instead, I can talk more about why we're actually going the other direction there. Second is the providers' misaligned incentives. Let's give you a flavor of that literature. I've reviewed it with co-authors. Our bottom line is that when doctors have conflicting interests, they act in accordance with those other interests. It can bias physicians' decisions. One example is from a 2007 study from Mitchell. She looked at a large California insurer. She looked at charges for PET scans, MRIs, and CT scans. And she looked for cases what are called self-referrers. These are allowed under federal law in various areas. But basically, non-radiologists who went out and bought an MRI machine so when they need to give an MRI to their patient, they can charge for that MRI themselves. They found that actually, this is back in 2007, it's probably been higher now, but a third of the MRIs were actually coming from these self-referring physicians, almost a quarter of the CTs. And interestingly, in 2/3 of the cases, they didn't even really go out and buy the machine. They were just leasing it or had some other convoluted system in order to capture those payments for themselves. So what do you think happens when a physician buys his own MRI machine or her own MRI machine? That's this study from Sharabati and Baker. They compared the physicians that didn't buy with the physicians that did, compared to how many MRIs they prescribed. And guess what? After you buy the MRI, you start doing more MRIs. Maybe it's because it's more convenient, maybe it's because you have better faith in the quality of the MRI, or maybe because you get some money every time you do so. And that's a pretty big relative increase, by the way, almost 32%. A study by Mitchell and colleagues in 2008 looked similarly at we have this provision in federal law that allows specialty surgeons to actually buy their own hospital. so that when they see a patient, they can not only charge the patient for the service of doing the surgery, but also charge the patient for the facility fee for doing the surgery. And guess what happens when people buy their own hospital? This is one, again, very granular instance of complex spinal fusion surgeries. Some patients do need these, some patients don't. There's actually two different kinds of spinal fusion surgeries. The simple ones, if you look at what happened between the people before and after they bought, the buyers here actually started doing fewer spinal fusion surgeries. Isn't that interesting? But what were they doing instead? Well, instead, they redirected their patients from simple spinal fusion surgeries to complex spinal fusion surgeries, saying, gosh, you need a big surgery. I need to use lots of time and bone cement and such. A 65 times increase after buying in this hospital. And you can see nothing else happening in this region with the control group. Here's a study of oncologists in 2010. The study looked back at a policy change that Medicare implemented so that oncology drugs would be reimbursed less at a lower rate. You'd think if we're reimbursing at a lower rate, and we might be able to save healthcare costs. Guess what the oncologists did instead? They started doing more chemo drugs. So this was the month when the implementation happened, and you can see all of a sudden they start giving their patients more chemo drugs. Chemo is kind of unique in our healthcare system because the physician also dispenses it. The physician kind of is her own pharmacy, so again gets to be, in that sense, a self-referrer. So ultimately, I think we have these big system factors about ignorance about efficacy, providers misaligned incentives. The second one is what economists would call an agency problem. And finally, the lack of competition. I'll talk just very briefly about it. The classic paper by Uwe Reinhardt, who said, the price is stupid. He passed away last year, and in a tribute to him, authors followed up on his 2003 article last year. And the bottom line is it's still the price. In the US, we have no competition, but we also have no price regulation for the most part. And so we just see higher prices for everything across the board. For example, if you look across hospital admissions generally, other OECD countries, you can get out of the hospital on average for about $11,000. In the US, it's double that, whereas in Germany, it's a fourth that. So there are ways to deliver essentially the same healthcare for around a fourth the price. So the solution to these three, I'm happy to be able to say in this setting, a law school, in my view, it's actually all three law. We need laws that force the producers of new medical technologies to actually do more and do better and more reliable research about whether their products are actually effective. We can't drive value if we don't know where the value is, if we don't know what's beneficial from what's not. Second, we need law to prohibit a lot of these misaligned incentives. I think physicians need to think of themselves more like experts than entrepreneurs. Physicians need to be paid salaries. They need to not be paid for doing more surgeries. They need to be paid for safety benchmarks and scientifically driven care. And lastly, I think the cat's out of the barn for trying to create functioning markets around healthcare for the most part. I think we're not going to turn back the clock and force the local hospitals to turn into 4 hospitals to compete with each other. For the most part, we need to use the power of a central buyer, a single payer, like it's done in other countries, or to drive down the costs. And so price control or monopoly buying is the solution to those virtual monopolies. I'll just mention that you got to do that because the monopolies are actually also enforced by law quite often. We actually have laws that give patents, so we create the monopoly. We have laws that require physicians to have licenses, so we give them market power. We have laws that require hospitals to get approval before building more beds. So in all these areas, the law is actually contributing to the monopoly power and the market power generally. And so I think the law's also got to be the solution. Okay, so we've talked about providers and patients and the system. I really think the effort needs to be on the providers and these system level factors. Interested in this, I've got, as David kindly said, a book coming out later this year. I always include my email because sometimes the best comments come a day later from someone who said, but what about this other thing? And I really would encourage you to reach out. Thank you.
chairs, so Brad and Chris can come up, and we can take about 15 minutes of questions for either one before we break for lunch.
So since we're in the law school, what do you think about the Optum United acquisition or lack of acquisition? You know about that, you're
I don't know about that. No, I don't.
the large medical groups are healthcare partners, and they have about 50%, maybe 60% of your lives. And then United has the other 47%, 1 or 2% are sitting out there. So for, what about 6 months, 8 months, it's been discussed whether the DOJ is going to allow this acquisition to go through. And you would think common sense would say they're not going to allow it to have one provider have 89, 90, 95% of the market, but they can't seem to make a decision on that.
So I got lost somewhere along the way. So United?
United Healthcare.
They're not really a provider, they're an
They're an
insurer.
insurance company. So they're an MA, they have their own medical group.
They're a provider in there.
They have a large medical group here.
Oh, okay, all right.
United Healthcare owns Optum.
Yeah, okay. All right.
So the most recent part of that is that merger was going to be a 6 to 8, 7 market thing. It was approved everywhere except Las Vegas.
Okay.
Now the need is trying to figure out how they're going to unload healthcare partners on a different route because it was so, it's going to be just beyond jail as far as monopoly.
My question was, why do you think the DOJ can't make a decision? Something that seems quite obvious to someone like me and not. Why would you allow monopoly to be created? They can't seem to make a decision on that.
Yeah, well, so I certainly don't want to speak for the DOJ.
You could do worse.
Yeah, I mean, I guess my own research into health insurance competition, hospital market concentration, and hopefully I tried to kind of like convey this a little bit with one of the scatter plots I showed, is that it's really complex. And so I think like what one would predict is good policy in one geographic market may not really hold for a different geographic market because everything is just so different. I've spoken at the DOJ and FTC on some of the research I've done, and everyone I've met there has been really, really thoughtful and detail oriented. So I'm inclined to think that they're handling all of this in a rigorous manner and just like being cautious. I mean, that would be my general impression. But yeah, it's hard for me to say without knowing too much about the particular. Sorry.
I wonder if it'd be useful to just add in the concept of vertical integration versus, horizontal integration. Bringing in functions into a single firm to allow management can sometimes create efficiencies that are better than bargaining between firms. And so my general view is some of the integrated healthcare systems that we have in the United States, like Kaiser, for example, on the West Coast, are actually doing quite well, in some ways better than some of the more traditional, bargaining between an insurer versus a provider. So that may be one of the things that make some of these mergers that have vertical aspects to them more interesting, where it's not simply about horizontal competition.
The problem is not all patients like Kaiser.
Yeah.
I mean, it works great for the minority of patients that appreciate that, but I think most patients want broader choice.
Dr. Aaron, going back to your comments about the inefficiency in the employer-sponsored group health insurance, is it your conclusion then that on the individual side where there's not that tax advantage, those plans are efficient, are healthier?
I mean, Yes, I mean, I wouldn't want to go so far to defend the whole structure of the exchange markets and how everything is constructed, but at a real fundamental level, the fact that somebody's subsidy for an exchange plan is fixed and doesn't depend on whether they buy a really expensive platinum plan or a cheaper silver plan, I think is a good thing. And I think that the fact that a subsidy is bigger for the platinum plan than the silver plan in the employment-based market is problematic. Yeah. So in fact, yeah. I mean, I think the ACA. I mean, it's convoluted as heck, right? Like second cheapest silver plan, and then like the subsidy like is indeterminate. I mean, it's kind of convoluted, but at some basic level, I think they kind of got it right. Sure.
So two very different questions from an economic point of view. One, you talked about the growth of Medicaid. How much do you think the public thinks of women and children of Medicaid? Obstetricians are precious, but the fact that the majority money goes, or a large percentage goes to nursing homes.
Yep.
With the aging population, how much do you think that's going to continue to support what happens in Medicaid? And are you keep nursing homes that's for all socioeconomic strata as opposed to Medicaid tends to be more for one question. And two, based on what you're saying, is it time to give up the World War II subsidy for employer help and just recruiting from employee things, since that charge keeps rising and most of our employees don't understand that's where the raises are going?
Yeah. So yeah, I mean, I would agree with the sentiment in both of your questions. It's look at the data. The majority of people covered by Medicaid, parents and their children, but the majority where the dollars go, it's for the duals, right? It's for the dual eligibles in Medicare. A lot of that is for the elderly, but also the disabled, and a lot of that is as you noted, like for nursing home facilities. And so yeah, in some sense, I think the big place where you'd want to try and focus getting better value is indeed like within the Medicaid program. It's the elderly and disabled. Conversely, for the Medicare program, it's really like the lowest income seniors where you want to I think concentrate those efforts. I think that's easy to kind of say. Yeah, that's